Hello, I'm audible now.
Yes, sir.
Someone messaged chat. Not audible. Right.
Okay, so
Okay. So can we go ahead? Dr. Kunal is joined now.
yes, sir. We'll start by sharp 5:30, sir.
Okay. Sure.
Okay, sir. Ms. Sri Lakshmi, I request you to join the event, please.
Am I audible? Hello? Good evening, everyone. On behalf of the International Association for Integrated Oncology, I extend a very warm welcome to all of you for today's session on expert insights on breast cancer. It's my privilege to welcome our program director of the session, Dr. Anbarsan S., a medical oncologist from Tata Memorial Center, Mumbai, to give the introduction and set the context. Over to you, sir.
Uh, Good evening, all. Thanks, Mrs. Srilakshmi, for giving me this opportunity. And also, I would like to thank IIO organization for this As a program director, I'm privileged to welcome one of my dear colleague, Dr. Kunal Jopanputra. We both were colleagues in Tata Memorial Hospital, and he gradually moved on to the MOC Center and practicing currently in Mumbai. With this, I would like to hand over to Dr. Kunal for his session on metastatic HER2-positive breast cancer in brain metastatic setting. Now, welcome, Kunal. Yeah, please go ahead.
Dr. Kunal, sir, you're on mute.
Am I audible now?
Yes, sir, loud and clear.
Thank you. Thank you, organizing team, and thank you, Dr. Anderson. It's been always good to interact with you. And thanks for the opportunity. So I'll be sharing some thoughts on a small brief talk on management of HER2 positive brain metastasis. My screen is visible?
Yeah, your screen is visible.
Thank you. Thank you. So it's a very niche topic of management of brain metastasis in patients with HER2 positive breast cancers. So HER2 positive and TNBC are the two subtypes where patients are predisposed to develop brain metastasis among patients with breast cancers. And almost one half of HER2 positive metastatic CA breast patients would might develop brain metastasis over lifetime. And now picking up of brain metastasis or incidence of brain metastasis is increasing due to the fact that we are more aware about brain metastasis, its management, its importance, more sensitive neuroimaging techniques, good MRIs which are able to detect brain metastasis, and also more and more because the survival of breast cancer patients is increasing day by day with newer therapies. So more effective systemic therapy, which increases the survival of the extracranial systemic disease. We need to understand that brain metastasis requires penetration of the blood-brain barrier and various changes in the tumor microenvironment and the cytokine level, which leads to penetration of these cells into the blood-brain barrier with increased expression of vascular endothelial growth factor and other mediators. And similarly, the management of brain metastasis also requires a multidisciplinary team decision making because it involves interplay of local therapy or systemic therapy or combination of both. So, what are the factors while we consider while treating brain metastasis, whether it is symptomatic or asymptomatic? What is the number of lesions? What is the performance status of the patient? What is the disease? What is the disease status extracranially? Whether the disease is a CNS dominant disease or a extracranial dominant disease, and if we have to treat it, whether it is a local or systemic or combined approach, and also the timing and the sequence of the therapies and what the gap is to be maintained between any therapy. And now with the advent of TDXT and tucatinib, systemic therapy is moving to the first choice in asymptomatic HER2 positive brain metastasis. So now local therapy, if we discuss in brief, so good or excellent performance status, small number of brain metastasis or large symptomatic lesions make the patient optimal candidate for surgery as the local treatment. Uh, uh, More basically when the patient lesions are very symptomatic, where it requires decompression or very few brain lesions. And if you resecting it, if the patient goes for surgery, then we should consider for serotactic radiosurgery, which reduces the chance of local recurrence. If surgical resection is not possible, then we employ the routes of radiation, which is radiotherapy versus SRS, depending on the disease volume. So SRS is indicated in the case of limited brain metastasis or if the cumulative volume of the brain metastasis is limited, while whole brain radiation is a low selective way to deliver the radiation to whole of the brain. It's reserved for patients who are unsuitable for SRS or for surgery or SRS because of the high volume or high number of the brain metastasis. Patients with very poor performance status, we sometimes very rarely have to consider for supporting care alone, but usually we offer them local therapy or good systemic therapy which can penetrate the brain. Now, for systemic therapy, there are two things that one is prevention of brain metastasis, delivering effective therapies to prolong survival and also to reduce the chance of development of brain metastasis. And also, once the brain metastases have developed, to manage them and to have a good response in intracranially, and that is a therapeutic way of managing the brain metastasis. So these were the initial trials which have been studied in the metastatic CA breast settings, except except TDXD and tucatinib. So the Cleopatra trial, as we are all aware, it had 808 patients, which compared a dual agent HER2 blockade with Taxane. And in this brain metastasis, patients with brain metastasis were not included. But the time to development of brain metastasis at the first site of progression was prolonged in patients who are on dual anti-HER2 blockade. And I'll be discussing briefly on each of these agents. So first of all, starting with the first basic agent, that is trastuzumab. So the data regarding prevention of brain metastasis and improving outcomes in patients with brain metastasis are mostly post hoc or retrospective. That trastuzumab, apart from improving the survival outcomes compared to patients who don't receive HER2 therapy, trastuzumab prolongs the time to development of brain metastasis, and also it prolongs survival in patients with brain metastasis also. But we all know that there is a lot of unmet need and newer agents have come. And but in resource constrained settings, let's not forget that other modalities like intrathecal trastuzumab have also been used to achieve a higher concentration of trastuzumab intracranially. And there have also been studies of usage of higher dose of trastuzumab, 6 milligram weekly, with pertuzumab after progression on radiation. But the response rate remains same, it doesn't increase. Now, pertuzumab, it is a synergistic action with trastuzumab, and Cleopatra study excluded these patients. However, exploratory analysis showed that pertuzumab prolonged the time to CNS metastasis by 3 months, and also the intracranial response rates by retrospective studies have shown around 90%. But almost 90% of all these patients also had received some local therapy in addition to the dual HER2 blockade. So that is a common regimen which we commonly employ in the first line metastatic HER2 positive, and even in brain metastasis, if they have received local therapy, then we do find that these patients have favorable outcomes. Now moving to the next therapy, which is a TDM1. So the Emilia trial studied TDM1 usage in second line after progression on the first line HER2. And the secondary analysis in these patients, in patients with asymptomatic brain metastasis, almost 95 were there, and it found that it improved OS by around 14 months compared to K-plapatinib with a hazard ratio of 0.38. Even Camilla trial, which studied the usage of TDM1 in subsequent lines after failure of prior HER2 therapies, also showed a PFS of 6 months and overall survival of around 1.5 years with a response rates for brain metastasis around 21%. Other retrospective studies for studying the response rates for TDM1 in brain metastasis have found somewhere between 20 to 40%, though it remains on the lower side of the range, and subsequently reinforcing the need that we need more effective agents for treating brain metastasis. And now, with the advent of TDXT, the advantage being that it's a higher payload to antibody ratio and higher membrane permeability. Starting from the DB01 trial to DB03, we have been able to see that the response rates exceeds 45% to going up to 60% with a good complete response rate also. So the trial, the Destiny Breast 03, which studied the second line HER2 blockade after prior progression, it included patients with brain metastasis around 18 number, and median PFS was 15 months versus 3 months, that is compared to TDM1, with a response rate of 67%, which was very impressive. There was a pooled analysis also of all these DB1, DB02, and DB03 trials, which included 148 odd patients, and 30% of them were untreated. And the response rates in untreated as well as treated was somewhere around 45%. And the complete response rate was also 15%, which was very impressive. This is the DB03 intracranial response, that is a CR rate of 27% and a partial response rate of 36% compared to 32% in the TDM1 arm, which shows that TDXT is highly effective in patients with brain metastasis also. This is the exploratory pooled analysis. This is the pooled analysis of DB01, 02, and 03 trials, which shows that the duration of response remains better with the usage of TDXT from 12 to 16 months compared to the comparator pool. So TDXT works irrespective, that is stable or even in patients with active or untreated brain metastasis also. Now, there are other trials which also studied the use of TDXT in active brain metastasis. There is a Tuxedo 1 trial, the DEBRA, the DB12 data, and also the Japanese real world study. So, Tuxedo 1, what was a single arm prospective trial in patients with pre-treated with TRAS2 and PER2, and also newly diagnosed untreated or active brain metastasis progressing after prior therapy, and it achieved a response rate of 70%, and the median PFS was 14 months, and median OS was not reached. Similarly, another phase 2 study, which was a DEBRA trial, which included patients with stable, untreated, or progressing brain metastases from HER2 positive or even HER2 low, and the 16-week progression-free survival rate was close to 80%, and intracranial response rate in asymptomatic brain metastasis was 50%, and in progressive brain metastasis it was 44%, and overall it was 46.2%, which was again promising and reinforcing the data that TDXT works in brain metastasis also. DB12 patients could have achieved, this was a phase 3B or phase 4 trial of usage of TDXT, and this was the largest available prospective evidence of usage of TDXT in patients with brain metastasis, where there were more than 250 patients with brain metastasis, and the 1 year PFS rate was 60%, and 1 year central nervous system PFS rate was 58.9%. And the patients, these outcomes were more or less consistent in patients with stable or active brain metastasis. This is the DB Destiny Breast 12 study design, where patients of brain metastasis were and also included, which was 263 in number, and TDXT was given every 3 weekly, and the primary endpoint was the progression-free survival. And according to the baseline characteristics, we see that these patients had received TRAS2, PER2, and even TDM1, and the primary endpoint, which was PFS, progression-free survival, was 17 months, and the 1 year PFS rate was 62% in stable metastasis, stable brain metastasis, and 60% in patients with active brain metastasis. So even in the active brain metastasis subgroup, that is untreated versus previously treated and progressing, the response rate was very promising. This is a similar curve which shows that the 1 year CNS progression-free survival in patients with stable and active brain metastasis at 1 year is somewhere close to 58.9%, showing consistent outcomes in both stable and active brain metastasis group. For the response rate also, it showed very promising curves as we promising plot as we discussed from the data, that the response is somewhere from 50 to 60% in various groups of brain metastasis. Now moving to HER2 CLIMB trial, which studied the use of tucatinib plus capecitabine plus trastuzumab versus capecitabine and trastuzumab. So they studied the addition of tucatinib, and here 291 patients were enrolled, were having brain metastasis, and active brain metastasis were majority of them, that is 174. And the response rate in the CNS was 47% compared to the comparator arm of 20. And median overall survival was 18 months compared to 12 months. And the progression or death hazard ratio was 0.32. There is also another trial which studies the usage of TDM1 along with tucatinib, which results are still awaited. So tucatinib is to be taken 300 milligram twice daily from daily for cycles repeated every 3 weekly, along with trastuzumab and capecitabine. This is the trial design of HER2 CLIMB, which studied the role of tucatinib plus TRAS2 plus capecitabine compared to TRAS2 plus capecitabine alone, and 47% of patients had brain metastasis in this at baseline. And in patients with, as we see from the curves, the updated OS as well as the intracranial PFS, the tucatinib plus TRAS2 plus capecitabine combination in patients with active brain metastasis, the median OS is somewhere close to 21 months compared to 11 months in the comparator arm. And if we look at the PFS in active brain metastasis, it is 9.6 months compared to 4 months, with a hazard ratio of 0.34. So tucatinib is the most preferred agent along with TRAS2 plus CAPE in patients with active brain metastasis. So now to summarize the data which we have discussed, that for the first line, we need to determine what is the symptoms and what are if the brain metastasis is symptomatic or not. If the brain metastases are active and local intervention is indicated, then we look for the number of brain metastases, and if we can if surgery is indicated, that is resection and followed by post-operative SRS. Or if the brain metastasis number is too many, then we offer SRS alone or whole brain radiation if the patients are asymptomatic. If local treatment is not indicated or the patients are asymptomatic, then we also look at whether this patient also has concurrent then we look at the first line treatment regimen which we offer in systemic therapy, that is dual HER2 blockade along with chemotherapy. And on subsequent progression, if we decide between TDXT versus tucatinib plus capecitabine plus trastuzumab, it's a choice where we usually see the extracranial disease, the patient eligibility for the same, and more or less we are inclined towards usage of tucatinib in patients with active brain metastasis. However, TDXT now with the latest data, it appears very promising in stable as well as active brain metastasis also. Another thing which we need to keep in mind is the radiation necrosis, where in these trials, trials which are studied, there is increased risk of radiation necrosis when TDXT or TDM1 is given concurrently. That is, usually it has been defined as around 2 to 4 week of gap. Different trials consider different studies had different gaps, but when it is combined with the RT, meaning to say that it had a gap of 2 to 4 weeks, there was a 1 in 4 patients developed some radiation necrosis. And even it's known for tucatinib usage along with capecitabine and trastuzumab, where it has been recommended to administer at least 1 week after SRS or 21 days after radiation. So commonly we keep a gap of around 2 to 3 weeks for to start the systemic therapies after local therapy has been delivered. I will just kept my talk very brief, and if any questions, I will be happy to answer.
Thanks, Dr. Kunal. That was a beautiful summary. I have a doubt. So the TDHD is showing good response in patient with active brain metastasis also. In this scenario, will you still proceed with the radiation, or you directly go ahead with the TDHD?
Yes, Dr. Anderson. So in patients who are with the advent of TDXT and tucatinib, we can safely go towards directly starting the systemic therapy if patients, because they have good response rate intracranially even for active brain metastasis.
Okay, thank you.
We thank
Audience?
NATCO for sponsoring that session. And now I would like to welcome our next speaker of the day, Dr. Anbarasan Yes, on a topic of what is next line after CDK4/6 inhibitor in hormone-positive breast cancer. Sir, over to you, please.
Yeah, thank you. So we quickly move on to this next session. I would like to summarize in a brief with respect to the. I hope my screen is visible.
Yes, sir.
So I will quickly summarize with respect to emerging therapies beyond CDK4/6 inhibitor. So this is how we are going to discuss with respect to the current landscape, mechanism of resistance, and different targetable pathway after CDK4/6 inhibition. So we all know that CDK4 irreplaceable part of treatment of hormone positive metastatic breast cancer setting. Often we have confusion which one to use. Either we have Palbase, abemaciclib, or ribociclib. This confusion always be there which sort of collection to choose, because all the three drugs have shown uniform advantage in terms of PFS. Even the hazard ratio is quite similar, but in terms of overall survival, different drugs has different benefit. And also when we go for subset analysis, some drugs have specific benefit also. But beyond doubt, we should consider CDK4/6 inhibitor along with hormone therapy in patients who are having metastatic breast cancer setting. It becomes first line of choice for majority of the doctors who are practicing. Unless patient having any other contraindication, we try to combine this combination in our clinical practice. Next doubt arises because after CDK4/6 inhibitor and hormonal therapy, what we face is a real challenge because after that, whenever we give chemotherapy or target therapy, the response rate is often poor. How poor it is? If we target with endocrine therapy along with targeted therapy in patients post prior CDK4/6 inhibitor, the median progression-free survival is only 5 to 8 months of duration, with chemotherapy somewhere around 8 months. So there is a big lacuna in management of metastatic 4/6 inhibitors. So what is the ongoing reasons for this kind of resistant mechanism or poor progression-free survival in patients who are exposed to CDK4/6? It could be either at the level of cell cycle regulatory element or it could be at the level of oncogene signaling mediators. What will happen at the level of cell cycle regulatory elements? It could be at the level of RBN, retinoblastoma 1 loss will be there. This is when CDK4/6 goes and bind with RB1, it phosphorylates RB1 and it removes the inhibitory brake on the cyclin E level. When RB1 itself lost, then the brake will automatically lost. It will proliferate continuously. Similarly, FAT1 loss, A or K loss, which will stimulate CDK6 pathway, as well as cyclin E amplification, again, which causes resistance to post CDK4/6 inhibitors. Another thing happens at the level of endocrine pathway or at the level of signaling mediator pathway. It can be at the level of PI3, AKT, PTEN pathway. We have multiple drugs which we are going to discuss in later lines. Second thing, it can happen at the level of RAS MAPK signaling pathway or at the level of receptor tyrosine kinase pathway, like at the level of HER2 level or at the level of FGFR2 pathway, which are underlying cause for the mechanism of endocrine resistance, be at the level of estrogen receptor, that is ASR1 mutation, at the level of HER2 amplification may be the cause, or at the level of signaling pathway, it can be at the level of PIK3CA, PKT, PTEN, AKT, or at the level of FGFR pathway. So these are all the multiple places or signaling cascade from the starting of receptor action to the level of cell cycle progression. So we can target at multiple places. We can consider HER2 targeted therapy if there is HER2 amplification is there. We can consider PIK3C inhibitor, AKT inhibitor, or you can even consider mTOR inhibitor in this situation. Coming to the targeting at the level of estrogen receptor pathway, that is at the level of estrogen receptor itself. This is called as Emerald study, which is a phase 3 study design, where the target drug is elacestrant in comparison with physician investigator choice, that is either fulvestrant and anastrozole in this setting. So they selected the patient who received at least 1 line of chemotherapy or less than 1 line of chemotherapy and endocrine resistant population into the setting. One key thing over here is only 10% of population have received CDK4/6 inhibitor into the situation in this scenario. And 1/4 of patient chemotherapy randomized into elacestrant 400 mg once a daily in comparison with investigator of choice. It could be either fulvestrant. Primary endpoint is a dual primary endpoint. One thing is, in general, overall population, what is the progression-free survival advantage? Second primary endpoint in specific with respect to patients who are one mutation, what is the progression-free survival advantage? And the key secondary endpoint include overall survival and response rate in this population. What we see over here is progression-free survival for elacestrant is 2.8 versus 1.9, whereas in patients who are having ESR1 mutation, it is 3.8 versus 1.9, which is statistically significant for ESR1 mutant population. Yeah, I can understand numerically this doesn't sound great, but when it comes to statistical analysis, it looks even better. But one key feature here is patients who are receiving CDK4/6 inhibitor beyond 1 year of duration, this combination works really better in this scenario. Next comes the drug called as immunolesertrant, which is studied in EMBER-3 study design, where they analyzed with respect to the combination of abemaciclib versus immunolesertrant as a separate agent, which is a SERD, selective estrogen receptor downregulator. What is the mechanism of action or what is the efficacy post CDK4/6 inhibitor in this scenario? Again, this SERD is a once a daily dosage, 400 mg once a day, in comparison with standard of care, and the third arm contains immunolesertran along with CDK4/6 inhibitor, that is abemaciclib in this scenario. Here they again studied for progressive survival in comparison with the also in comparison with the dual arm. what they found out again here is an interesting study. There is advantages there, but numerically it is not so great. But when we isolated a subset of population, that is those who received CDK4/6 inhibitor beyond 1 year of duration, both as has shown significant. In Emerald study, the median PFS improved from 2 months to 8.6 months with an hazard ratio of 0.4. Also in Ember 3 study design, the median progression-free survival improved from 5.5 to 9.4 months with an hazard ratio of 0.57. So this again indicates that when the patient is having endocrine sensitive disease, this combination works much better and able to provide better progression-free survival in terms of using elastin as well as immunosuppressant in this population. Coming to the oncogene signaling pathway inhibition, it could be at the level of PIK3CA, AKT, or mTOR pathway. So we all know that up to 50% of hormone receptor positive, HER2 negative breast cancer have genetic changes with respect to PIK3, AKT, and PTEN pathway. And PIK3 alterations is a constant marker. It happens at the level of baseline itself. So even at the level of baseline breast cancer or de novo metastatic breast cancer setting, almost 40% of population have PIK3CA mutation in this scenario. Whereas with respect to ESR1 mutation, ESR1 mutation is a dynamic marker. It can having 2 to 3% of patients may have ESR1 mutation, but over a period of time with exposure to endocrine therapy and CDK4/6 inhibitor therapy, this mutation level can rise up to 40 to 50%. So this is the key difference with respect to ESR1 mutation and PIK3CA mutation in this scenario. With respect to AKT and PTEN can contribute around 10% of population in this scenario. So where do we consider testing for PIK3CA, AKT, and PTEN in this scenario? Whether we want to do the testing at the level of diagnosis or at the level of metastatic setting or anything. Most of the guidelines recommend that you can consider testing at the level of diagnosis also, because during the time of progression, detecting PIK3CA might be a challenge. So considering at the first line will be more of a beneficial for this population. And also we can titrate the therapy in the first line also, because there is a drug called as inavolisib getting approved in the first line setting for endocrine resistant population in this scenario. Coming to the targeted therapy, which are available for targeting PIK3CA, AKT, PTEN pathway. This drug is known as capivasertib, which is studied in Capitello 291 study, where we able to see the patient who received prior 2 lines of endocrine therapy or 1 line of chemotherapy has been taken into the study design. Both pre as well as post-menopausal patient has been taken into the study design. They have a criteria, HbA1c should be less than 8, and diabetes not requiring insulin has been taken into the study design, because we know that either those drug which is acting at the have propensity for inducing diabetes mellitus in this population. So they have taken the population only with HbA1c less than 8 taken into the study in this population. Other characteristic features before noting down into the studies: how much percentage of patients who are exposed to prior CDK4/6 inhibitor, how many percentage of patients had secondary endocrine resistance, how many percentage of patients had AKT pathway alteration. So close to 70% of patients had prior CDK4/6 inhibitor exposure, 60% of patients had secondary endocrine resistance, and 40% of patients had AKT pathway alteration in this scenario. Here again, the primary endpoint is a dual primary endpoint. They see progression-free survival for an overall cohort, as well as they have seen progression-free survival with respect to AKT pathway altered pathway mutation in this scenario. And the key secondary endpoint include overall survival and an objective response rate. Another interesting thing with respect to capivasertib study design is it is not a they have been given at a dosage of 4 days on and 3 days off. So it gives amount of recovery time for the patient to recover from the drug-related toxicity. Coming to the primary endpoint again, the drug has shown advantage in terms of progression-free survival, even in it has improved in overall population as well as with respect to PIK3CA, AKT pathway related mutation also. But the FDA has given approval for capivasertib in population who are expressing PIK3CA, AKT, and PTEN receptor mutation only. So this is with respect to the subset analysis with respect to different alteration, that is PIK3A alteration, AKT, and PTEN alteration. Again, it has shown benefit across 3 different types of alteration also. Coming to the safety profile, we need to be a little more cautious with respect to capivasertib, because the combination has shown discontinuation rate of close to 10% because of the adverse event, and serious adverse event seen in close to 16% of population. And these are all the other drugs which are being approved with respect to the AKT pathway alteration. We all know that alpelisib, which has got approval based on the SOLAR study, which has shown good amount of PFS advantage. Again, the drug has shown multiple adverse events. That's why it is not commonly used in the clinical practice. The disadvantage with SOLAR study design is only 10% of population had CDK4/6 inhibitor except. To avail this disadvantage, there is another study called BioLive study, where almost 70% of cohort has received CDK4/6 inhibitor. Again, in those patients who received CDK4/6 alpelisib has shown advantage. Next comes the everolimus, which is been long lasting more than a decade or so. Again, it has own side effect like stomatitis, fatigue, dyspnea. That is why it is not so commonly used. Another disadvantage with respect to everolimus is everolimus, we don't have any prospective or retrospective study to show how much beneficial, especially in patients who are prior exposure to CDK4/6 inhibitors. Coming to other pathway, that is, can we target other than AKT alternate pathway, oncogene signaling pathway, or we can target alternative to HER2 pathway. That is the key. Here we are going to discuss, that is targeting HER2 pathway in this scenario. There are two trials which are published with respect to targeting HER2 pathway in hormone positive metastatic breast cancer setting, that is Destiny-04 and Destiny-06. There are two key difference with respect to Destiny-04 and Destiny-06. In Destiny-04, they have taken population who are taken chemotherapy in the prior line. 1 to 2 prior line of chemotherapy has been allowed in the study. Second thing is they have taken only HER2 low, that is HER2 IHC 1 plus or 2 plus and FISH non-amplified has been taken into the study design. 06. They have been randomized in a ratio of 2:1 with respect to TDXD and treatment of physician size. It could be either capecitabine, eribulin, gemcitabine in the arm. The primary endpoint here is progression-free survival, and key secondary endpoint include overall survival, response rate, and duration of response in the population. Coming to the primary endpoint, that is progression-free survival, it has shown median progression-free survival advantage of 10.1 versus 5.1 months in a hormone receptor positive cohort with an hazard ratio of 0.51. So it is showing a meaningful advantage for hormone positive population also when we use TDXD in this scenario. And it has translated into overall survival advantage also, that is 24 versus 17.6 months in patients who are having hormone positive population. Moving on to the next part, can we move TDXD in a much earlier setting? That is, even before giving chemotherapy in a chemo-naive population, can we consider TDXD in this population? In Destiny-06, another important point is, well, can we include HER2 low? That is 0 to 1 plus. Can we take those population also into this scenario? So this is an ongoing study where they are trying to target patients who have received multiple lines of endocrine therapy, and they have, or the patients who have progressed less than 6 months of first line of endocrine therapy has been versus treatment of physician choice. Again, here the primary endpoint is progression-free survival. This is with respect to the baseline characteristics. It is uniform across the population in this scenario. Coming to the progression-free survival advantage over here, the delta here it is 5.1 months. Median progression-free survival is 13 versus 8.1 months and hazard ratio of 0.6. Again, it is showing a promising effect in terms of progression-free survival, but we have to wait for the overall survival advantage, which is yet to get published. So the side effect profile is more or less similar in comparison with the treatment of physician choice arm. Some side effects like nausea and neutropenia is slightly higher compared to the chemotherapy arm. Coming to the special interest, adverse event of special interest in terms of cardiac failure, left ventricular ejection fraction, it is on the lower side. Even though it is an anti-HER2 directed therapy, still the left ventricular ejection function or cardiac dysfunction rate is much lesser with respect to TDXD in this scenario. Coming to the other ADCs which got approval with respect to hormone receptor positive breast cancer setting. First comes the datopotamab deruxtecan. Here the payload which is similar to the TDXD, but the targeting molecule is slightly different. In TDXD, the targeting molecule is HER2. Here it is TROP2. Here again, the trial has shown progression-free survival advantage, but overall response rate is much higher. Overall survival advantage is not seen. But the authors prefers to use datopotamab compared to sacituzumab govitecan because of the better safety profile compared to the sacituzumab govitecan. Whether we can sequence ADC like TDXD followed by sacituzumab govitecan or CDXD followed by datopotamab, it is still under evaluation. We need to see more into the real world data to see whether it is beneficial or not. Coming to the re-challenge, whether it is beneficial of with respect to but can we continue CDK4/6 inhibitor beyond progression also? There are a couple of trials like maintain study, PACE study design, and Palmyra study designs are there. This is with respect to usage of palbociclib in this scenario, and then maintain study with respect to shown PFS advantage, but there is no OS advantage. Next comes post-MONARCH study design. Again, abemaciclib continuation beyond CDK4/6 along with fulvestrant in this scenario. With respect to progression-free survival, it has shown advantage. It has shown numerical advantage also compared to 12.9 versus 5.6 months in this scenario. Coming to the conclusion, we all know that CDK4/6 inhibitor is the standard of care in terms of metastatic hormone-positive breast cancer setting, but the treatment paradigm is still unclear beyond CDK4/6 inhibitor. So one treatment regimen will not fit into all set of patients. We need to analyze for the presence of targetable therapy in the population. If the targetable mutation is there, then we can consider targetable therapy, including for BRCA1 and 2 germline mutation in the population. If those mutations are there, definitely we can consider for targetable therapy. In case we are not getting the targetable therapy, then we can consider either re-challenging with the CDK4/6 inhibitor based on the clinical profile, or we can consider anti-HER2 therapy in the population. For this, I would like to thank organizer for giving me this opportunity. Any questions, we can take it on. Thank you. To the next session. My slides are visible. Hello,
Yes, sir.
am I audible?
Yes,
Yeah.
sir.
Okay. So we will go on to the next session with respect to the panel discussion, which is supposed to be done by Dr. Shrikant sir. Unfortunately, he is not available due to his schedule change. So I will proceed with moderation of the session. I think my panelists, Dr. Lakshma, Dr. Satish, Dr. Syed, Dr. Karan has joined.
Yeah, Anbasan, you are audible. Yeah.
Yeah, so we proceed with the moderation. This is with respect to the sequencing strategy in HER2 positive metastatic breast cancer setting. I think Kunal has given overview with respect to the management of metastatic breast cancer, especially in brain metastatic setting. So we quickly review how the treatment paradigm evolved with respect to HER2 positive metastatic breast cancer setting. So this is with respect to HER2 targeted therapy. This is one good area in solid tumor where it is one of the solid tumor where it has better overall survival advantage compared to other solid tumors. Definitely, I can say, because there are more and more of inventories, newer drug options are available in this scenario. So we started with trastuzumab, which has started showing difference in terms of overall survival advantage. We quickly had pertuzumab, that is Cleopatra, based on which we started getting the approval. Then we have newer antibody drug conjugate coming to the picture in terms of TDM1, TDXD. All these things are coming up into this scenario. How we are going to optimize this therapeutic sequencing with, especially we having multiple options, how we are going to optimize this therapeutic sequence in this scenario. When it comes to first line of HER2 positive metastatic breast cancer setting, we have the Cleopatra study design, which is approved more than a decade ago. Here we try to utilize combination of dual anti-HER2 therapy, that is pertuzumab, trastuzumab, along with chemotherapy in this scenario. Chemotherapy here is given for a limited duration of time, and then we can try to continue pertuzumab and trastuzumab if the patient showing good response in this scenario. Here the primary endpoint is progression-free survival, but this trial has shown overall survival advantage also. It is a landmark overall survival advantage. 8-year overall survival is 37% in the study arm, that is Pertu and trastuzumab combination, whereas in the control arm, it is only 23%. That is 14% overall survival advantage is there. In terms of progression-free survival also 18 versus 12 months. Here the overall response rate is 80 months. So with this, Dr. Satish, how would you plan your first line of treatment? Will you still go with trastuzumab, or your patients are affording for pertuzumab also in the current era because biosimilar pertuzumab is available? What is your opinion with regard to it?
बोले तो ऑपरेशन वालों के पहले तो लीजिए, हमको क्यों बुला रहे हो, पर जाओगे बुला के।
ठीक है,
Satish, are you there?
Yeah, I'm there. So, in scenario, this many of my patients are there affording for pertuzumab, especially for the patients, especially when we have Ayushman and when we tell them there's the benefit of PATCR. So many patients they do afford, and in my practice, almost around 30 to 40% of patient after this biosimilar has been launched by Indian companies, around 50% of 30 to 40% of patients we have converted from single HER2 blockade to dual HER2 blockade.
Okay, that's really heartening to hear. Lakshma, in your opinion or in your practice,
I think it also wasn't because we have here in my place, we have, apart from Ayushman Bharat, we have something called as Mukhyamantri Gambhir Bimari Yojana, where these newer drugs are getting covered in that.
Oh, that's really nice. So even immunotherapies are available with the
With
the scheme?
immunotherapies. Right now, I'm sitting in this RCHRC OPD of Ranchi, and almost every third patient we have been putting on low dose immunotherapy, and people are actually.
Okay. Dr.
So I
Lakshma,
think
your
the
opinion with
state government schemes, the schemes of government really helps. Like we have a scheme of around 10 lakhs, and that Kiran, most of the in Kiran, all the 10 lakhs gets used, and then people they do afford normal chemotherapy when they are counseled properly.
Okay, that's good. Dr. Lakshma or Dr. Sai, what's your opinion with respect to usage of pertuzumab after arrival of biosimilar in Indian scenario?
So in my scenario, around 30 to 40% of my patients is now affording for pertuzumab due to the availability of that Indian biosimilars, and these are mostly we counsel the patient regarding the use of this, and if they are not affording and not financially, then we go for only trastuzumab only.
Okay. Lakshma, your opinion?
So I also agree with Dr. Sayak. Even in my practice, it's only 30 to 40% of the patients will be affordable for pertuzumab, in spite of having the generic available.
Okay, that's great.
But I would prefer giving dual anti-HER2 blockade. That would be definitely.
Yeah. So still dual, the more advantage with the dual targeted therapies, the toxicity profile is more or less similar. So we often tend to give the dual anti-HER2 therapy if the patient is not having much toxicity. Dr. Karan, your opinion is also similar, or any slight change with respect to the usage of pertuzumab?
I think, sir, in our setting, along with you, we are using more, pertuzumab in our practice. I think the number should be crossing more than 50%, and definitely we are seeing that the outcomes are better.
Yeah, that's true. So coming to the next part, that is Destiny 09. I know this is one of the breakthrough indication because going with a chemo-free regimen. Ideally, it should not be called as a chemo-free regimen because TDHD again is a form of chemotherapy only. It contains S1, which is nothing but an irinotecan coming into it. But they project as an antibody drug conjugate along with pertuzumab. They are telling it as a chemo-free regimen. They have recently published that it is showing statistically significant improvement in terms of progression-free survival. Satish, your opinion with respect to usage of combination of TDHD and pertuzumab? Can you select some patient with respect to usage of TDHD and pertuzumab in your scenario?
I think Anubharan, that TDXD and pertuzumab, and I have not used TDXD plus pertuzumab. I don't know whether you people, how
Okay.
frequently you people are using it.
So do you have any exposure to patient who are like chemotherapy ineligible? In those patients, you would like to consider TDHD with pertuzumab?
Definitely,
Or
I think all the geriatric patients are not willing for chemotherapy. Like we get a couple of patients once in a while where the patients, they are highly HER2 positive and they're not fit for the PS is not good or the age is not good. In that subset of patient, I think it will be a way forward that we use this combination.
okay, I think we have to get for a more mature data to see how it is working in our Indian scenario. I feel the thing is, even though they tell us a chemo-free regimen, still TDHD should be continued. You know, the median progression-free survival is close to 3 years. So if, with TDHD alone in a second-line setting, the median progression-free survival is 28 months. And with the combination of TDHD plus pertuzumab, in a first-line setting, the median progression-free survival close up to 3 years duration. So again, maintaining the drug for 3 years is a big challenge. We need to get a full paper data. What is the toxicity profile and how much is the complaints of the patient with respect to TDHD plus pertuzumab? Because it is not as easy as continuing Pertu and Trastuzumab in our scenario. Continuing TDHD will be a major challenge because you need to manage for hair fall. TDHD associated with lot of hair fall, lot of nausea will be there, and it is an IV presentation. Again, patient need to come every time with a blood test to the OPD. All these challenges are there. Definitely, we need to check the full paper data, and also we need to wait for the overall survival data to get more into the combination of TDHD plus pertuzumab in our scenario. Coming to the second line option, so this is the Amelia study design, which is compared with capecitabine. It has shown PFS advantage and also advantage in terms of overall survival, close to 4 months overall survival advantage is there. Next comes the another option, that is Destiny 03 with usage of TDHD into the scenario. It has shown PFS advantage. Again, it has shown OS advantage also. So we have good amount of option, either TDM1, TDHD, capecitabine. Most of the time, we don't have multiple option in a second line setting. Lakshma, your opinion with respect to usage of which is your go-to option in second line setting, TDHD, TDM1 or capecitabine?
So for me, I would definitely in second line counsel for TDXD if they are affordable and if the patient is fit. If they are not affordable, then I would go for TDM1.
Okay. Dr. Sayak, your opinion with respect to usage of TDHD versus TDM1? I know capecitabine is little outdated. If
Yes.
TDHD or TDM1, which one you prefer?
So mostly we counsel the patient in the second line that, as Dr. Lakshma told, that first counsel the patient for TDXD. If not feasible, then TDM1. And if TDM1 not feasible, then we can go ahead with capecitabine plus lapatinib. But since now there is also and so mostly we go for mostly I use mostly in second line. TDM1 is the most preferred option because TDXD is not very affordable to most of the patients now.
Yeah, I agree. So you can keep it for another next line of option.
Yes.
Dr. Satish, your opinion with respect to usage of TDM1 versus TDHD in second line. Will TDHD also get covered in the state scheme which is provided over there? Dr. Karan, would you like to take this question? What is your preferred option?
So,
I think
sir,
Satish is
with
facing some network issue.
So, sir, I mean, with the Amelia, we came to know that TDM1 had superiority over LabCap, and with the current data of TDXD, we don't have much of the data supporting that. What would the sequence be? Should TDM1 followed by TDXD give us a better PFS, or TDXD followed by TDM1? I mean, that is a data-free zone, but definitely with the results of TDXD coming in, TDXD should be preferred if financially viable. Otherwise, TDM1 and then followed by CapLab would be a suitable option, sir.
Yeah, I also agree with most of my all my panelists that TDXD has shown one of the promising data. The median progression-free survival improved by 4 times. So 7 months versus 28 months, which is unseen of. So 4 times improvement in terms of median progression-free survival. Definitely, I would like to consider. And also the amount of CNS control rate, which is seen with TDHD, is also huge compared to TDM1. So especially in subset of population like those who are having brain metastasis, I would like to consider TDHD over TDM1. But some patients who have minimal progression or oligo progression, then maybe you can consider TDM1 also. Another challenge with respect to usage of TDXD is you can consider in a hormone positive, HER2 positive metastatic breast cancer setting, you can consider usage of CDK4/6 inhibitor as a maintenance therapy also. Dr. Lakshma, have you started using Patina study as
So your question was not audible. It got
So
just
my
got
question is,
disconnected.
have you started using Patina kind of regimen using CDK4/6 inhibitor as a maintenance therapy after patient first line Perto trastuzumab?
No, sir. Until now, no.
No, start. So it is showing median
I'm
PFS
not.
advantage of 22 months. Yeah, you can consider using it. We actually started using CDK4/6 inhibitor as a maintenance if the patient exhibit partial or complete response in the scenario. Then moving on to patients who are in second line with brain metastasis, because brain metastasis is one of the important prognostic factor. We all know that when the patient is having brain metastasis, the average survival rates from 4 months to 1 year. But with the arrival of newer anti-HER2 therapies, even the progression-free survival crossing 60% more than 12 months. 12-month PFS is crossing more than 60% of population. So it is a very good sign, but in this era actually. So is brain metastasis baseline evaluation, or it is only on the symptomatic appearance? Karan, what is your opinion? Will you consider brain metastasis workup like in lung cancer? In a stage 4 disease, we often consider MRI. And do the same thing with you keep only for the symptomatic patient. What is your opinion?
So, sir, HER2 positive has a high propensity to have brain mets, and I mean, it's not regular that we would do brain MRI, but definitely if patient has symptoms, we should be doing a brain MRI. I think routinely we are not doing that, but I think symptom patients who have symptoms should be undergoing brain MRI.
Yeah, that's correct. Shaik, your opinion with respect to MRI brain
So
at
mostly
the baseline?
So in mostly we don't do as a procedure. Mostly in the patient is symptomatic, then mostly we do the brain MRI. And if the initial PET scan shows just picks up some, although PET scan is not a very good modality for detecting the brain mets. If the PET scan in the CT shows some suspicious brain lesion, then we can do an MRI. Otherwise, we mostly do under the patient is symptomatic.
Okay. Dr. Ramjas, sorry I missed you. Hope you are there now. With respect to asymptomatic,
Yes, sorry, sir.
only for the symptomatic patient.
I missed, sir. Yes, you are not audible, sir. Can you repeat the question, sir?
So my question is, do you consider MRI brain at the baseline only? Like in lung cancer patient, we consider MRI at baseline irrespective of symptom for the brain metastasis. Or you consider only in patient who are symptomatic? How you proceed in HER2 positive breast cancer setting?
No, sir. So even patient with metastatic disease, I don't prefer it baseline. If patient symptomatic, if he is complaining of even mild headache or some that symptom, we do MRI, but we keep a low threshold for MRI, but we don't do routinely on it baseline.
Yeah. And how frequently you encounter brain metastasis in HER2 positive setting? Whether it is more common in the first line or it is more common in the later line of treatment?
Yeah, definitely. At baseline, that patient came with that around 30 to 40%, but definitely in second line is more than the 50-60%.
Yeah, correct. I also agree with Dr. Ramjas. You know, the as the disease progression happening, this is much higher. So we see around roughly 30% of patients at the baseline presenting with brain metastasis, whereas the rate goes up to 60 to 70% in subsequent line of treatment. So brain metastasis is one of the important prognostic factor, and to target is also much more important. But unlike lung cancer, it is not fully evolved. But there are some data are showing that your screening with MRI will have an impact. What are the factors to consider in treating brain metastasis patient? Local therapy or systemic therapy? I think Dr. Kunal has elaborated nicely with respect to the brain metastasis in HER2 positive setting. How you proceed with respect to local therapy? How much amount of metastasis should be there? There you consider local therapy as an add-on. Anything like that? How you proceed with curative intent? Dr. Lakshma, your opinion with regarding that, treating brain metastasis with local therapy and systemic therapy? Or Dr. Sai? Sai, with respect to usage of brain metastasis, which part of therapy you will consider, local therapy or systemic therapy in the scenario? How you decide to go with local therapy or systemic therapy?
Hello.
Yeah, Sai, you are
Hmm.
audible now.
Yes, not well. No, okay. So in a mostly in patients with brain metastasis, if the patient is very symptomatic, then we can go ahead with whole brain RT, or we can also go ahead with mostly we go ahead with whole brain RT, and also we can go ahead with the SBRT also if there is very only a single lesion, and also the extracranial disease is well controlled. Then we can go ahead with the SBRT or the SRS to the brain lesion also, and we should change the systemic chemotherapy option in case of if the patient is progressing on the if in any targeted therapy. So mostly the first line will be the TDXD, and and also in the third line, as I've seen that if the patient is affordable, then also we can go ahead with, if it's not affordable for TDXD, then we can go ahead with that tucatinib plus capecitabine plus trastuzumab, because it shows that in case of that there's a very good overall response rate in the brain lesion.
Yeah, I agree with Saik. So Saik, have you started using tucatinib in this scenario? How is your experience with respect to usage of tucatinib?
Tucatinib I have only used only a single patient. The patient scenario is that he had received TDM1 and he was not affording for TDXD, and we have given tucatinib, and since 3 months she's now stable. On the
Yes.
MRI it shows the stable it is.
Yes, actually, it is a real big boon for
only one patient, but nothing else.
one
No.
patient. Yeah, correct. The cost is one of the crucial factor again to tucatinib with respect to that. But I feel it is a really good boon in this scenario because most of the time TDXD is not affordable for our Indian patient. This availability of tucatinib increase the option profile with respect to management of HER2 positive metastatic breast cancer patient. And this is with respect to the HER2 CLIMB study. Kunal has elaborated really well with respect to usage of tucatinib in brain metastasis patient. Here again, they show 1 year overall survival of 70% and 2 year overall survival of 48%. And one important thing with respect to HER2 CLIMB studies, they have taken active brain metastasis also into the consideration. Whereas with respect to Destiny 03 as well as Emilia study, they have taken only stable brain metastasis patient into the study. So this was one factor with respect to the launch of, at the time of launch of TDXD. You can consider tucatinib when the patient is having active brain metastasis. This is the reason behind it, because the median overall survival is also 21 versus 12.5 with a delta of 9.1 month is seen. So my question to the panel members is, if the both tucatinib as well as TDXD's options are available for the patient with active brain metastasis, which one we would like to prefer, TDXD or tucatinib? Karan, your opinion with regard to that?
Sir, I mean, I'll firstly go to your last question where you said that how would you sequence therapy in local versus systemic? My take is probably if a patient has some mass effect or is highly symptomatic, then brain RT, WBRT would be a suitable choice. Also, depending upon the number of brain metastases, if it's like less than 10, they are less volume, probably we'll try to do some SBRT to these lesions. If the patient is asymptomatic or patient has leptomeningeal disease, probably a systemic form of therapy in terms of TDXD would make more sense. But in terms of sequencing, I mean, volume of disease, number of lesions would definitely come into account for sequencing therapy. And
Yeah, correct. Go ahead.
Yeah, and regarding the tucatinib and TDXT, I think, sir, we've had more experience with the TDXT till now. Haven't started any patient on tucatinib, but yes, definitely looking at the intracranial responses, uh, TDXT first followed by tucatinib would be a much preferred choice, sir.
Yeah, I agree with you, Karan. Ramjas, your opinion with regarding to usage of tucatinib versus TDXD in brain metastasis patient, especially those having active brain metastasis?
Yes, sir, definitely, sir. If patient is afforded for that TDX, even low dose 100 mg, I start if patient affordable. If not affordable for even 100, then we'll definitely go for that tucatinib. But recently we have not used that tucatinib that has been launched. But in future we'll see the response and we'll start. Will I get the chance? But patient who is affordable will go for that TDX only, sir.
Yeah, correct. I think majority of them agree to the point that TDXD is definitely good drug even for those patients with a brain metastasis. But only factor which hinders the usage of TDXD here is cost. So cost is the major factor which is deciding it. But one good thing is we have tucatinib as an alternate option, especially those patients who are having active brain metastasis in this scenario. And this is with respect to the patients who are having active brain metastasis. Even with active brain metastasis, the progression-free survival at 12 months is 35%, and median delta of 5.4 months is seen. And overall survival advantage is also there with a delta of close to 9 months. The data is really promising with respect to usage of tucatinib in this scenario. And even in stable metastasis, again, it is showing, but OS advantage is not that great. So if the patient is having active brain metastasis, then definitely it comes to the picture. Coming to the next part of the question, that is TDXD in brain metastasis, I think all our panel members have agreed that even in brain metastasis, the response rate is quite good. Different sort of trial with respect to TDXD has been done in this scenario. The response rate climbs as high as 70%. So you can still consider using TDXD in this scenario. One of the clinical situation which I recently encountered is in a HER2 positive breast cancer patient we previously treated with radiotherapy. Patient was on TDM1 and then again progressed in brain one lesion was there. The option of giving radiotherapy was there because patient has received radiation three years before. So still the option of giving radiotherapy was there. But the RT people themselves have denied the radiation because TDXD is a very favorable option with a response rate of 70%, which they can't provide with WBRT. Even though patient was symptomatic, we gone ahead with TDXD in that scenario, and TDXD has shown very good response for the patient, and patient is still continuing with TDXD in this situation. So you can consider TDXD even in patients who are having active brain metastasis also. I think this factor we have discussed with Dr. Karan and Dr. Ramjas, and sequencing also Dr. Karan has explained clearly. So this is the way to proceed in patient with active brain metastasis. Tucatinib with trastuzumab capecitabine is a definitely good option because of the response rate and the overall survival advantage it is showing in this scenario. Also for patients possible to differ local therapy, CNS responses decide, again tucatinib comes into the picture. When the patient is having both systemic progression as well as CNS disease, then TDXD plays much higher role compared to tucatinib, trastuzumab, and capecitabine. And patients who are not affording in this scenario, you can consider capecitabine is still a good option. In those patients, status remain co, then you can consider TDM1 or TDXD in this scenario. My panelists, any alteration you want to see with respect to this scenario? Active brain metastasis, your opinion? I think Ramjas and Karan has agreed for TDXD. I think I also likely agree with TDXD. I think Dr. Srikanth has made this slide. That's why he preferred tucatinib with trastuzumab. But it will be a second good option for keeping in those population with tucatinib and trastuzumab in this scenario. Lakshma, your opinion with regard to this scenario? Active brain metastasis, your opinion?
Even I would go with TDXG, sir. Post
Yeah.
progression on TDXG only, I would prefer tucatinib with K. Yeah.
Okay, that's great. I think everyone uniformly agree that TDXD is showing better response, and tucatinib is a definitely favorable option for brain metastasis patient. And these are the other possible regimen for brain metastasis, combination of TDM1 with tucatinib. We are yet to get the overall survival data, but PFS data is not so promising. So we have to wait for the overall survival data, whether it is good enough or not. Again, the other combination which are not available in India, like niratinib in combination with capecitabine and pyrotinib in combination with capecitabine. Again, here the response rate is only 40%, whereas with tucatinib it is up to 70%. TDXD it is 70%. with respect to interest of time, I'm moving faster. HER2 climb again 02 is a study where they studied about combination of TDM1 along with tucatinib. The response rate is 37%. Median overall survival yet to get a full paper in this aspect. I think anyone would like to prefer TDM1 with tucatinib. Dr. Sayak, your opinion with respect to combination of TDM1 with tucatinib?
If the patient is on TDM1 and if the patient is on TDM1 and there is some single brain progression in the brain, then we can add tucatinib to TDM1 in that setting.
Yeah, that's correct. Actually, even before the availability of tucatinib, we tried to use something similar combination with respect to lapatinib.
TDM1 plus lapatinib have used, so in that setting also
Lapatinib,
use TDM1 plus tucatinib.
Yeah, so these things always happen. We try to combine different agent with this thing. I often combine some scenario like when the patient is on pertuzumab and there is local progression is there. I try to add capecitabine to maintain the response because that time the pertuzumab comes with a PAP program. So we try to add capecitabine whether the response is continuing that or not. Even though there is no randomized data is there, but still this practice of adding some other agent to the main backbone to improve the survival rate, especially when the patient is having oligoprogression. Coming to third line and beyond, there is not much sequencing with respect to third line HER2 positive breast cancer. Again, this is one of the important study, HER2 climb, usage of tucatinib with trastuzumab and capecitabine. Few months before, was not a possible option in our Indian scenario. Currently, we have a lot of generics are available with respect to tucatinib, and thus it is showing advantage in terms of both PFS as well as overall survival also. Again, TDXD we can consider even for patients have exposure to TDM1 in this scenario. So how would you like to choose third line agent? You'll go with TDM1 or TDXD. What is your mode of choosing? Ramjas, your opinion with respect to third line option? And what all factors you will consider in this scenario? Ramjas, am I audible?
Yes, sir. Can you repeat, sir? Just once.
So how will you choose third line agent? What are all factors you consider for third line metastatic hormone HER2 positive breast cancer?
Sir, in third line sequencing is not such what the regimen we have not used in first, second. We can use like first line that trastuzumab, pertuzumab, docetaxel or paclitaxel, then TDX. We have used then TDM come and then tucatinib, trastuzumab, capecitabine. So these are the lines of therapy, but there is no ideal sequencing beyond that second line.
Yeah, I agree with Ramjas. There is no ideal sequencing, but the options are still available. We can consider anti-HER2 therapy only, or we can go with chemotherapy backbone also, or we can consider adding CDK4/6 inhibitor if the patient is having triple positive in this scenario. These are few drugs which is not available in India, but tried with respect to use in HER2 positive scenario. I think fourth line, I don't want to go much into it. And this is with respect to ESMO MCP guidelines in April 2025. It has updated with respect to usage in different setting. With this, I would like to thank all my panelists, Dr. Lakshma, Dr. Sayak, Dr. Ramjas, Dr. Karan, and Dr. Satish for giving this wonderful opportunity and making this session much more better. I think we can move on to question and answer session if there is no other doubt or no other questions. There were a lot of questions in the chat box. I think one question is why other combinations are not available in India? Probably the patency is not dissolved. Probably that is one reason why it is not yet available in India. There was an option for using pyrotinib based trial in India, but it is not fulfilled. Probably if the trial is done over here, be able to get more into the option of using pyrotinib in our scenario also. With this, I would like to hand over to the organizer. I would like also thank the organizer once again for giving me this opportunity. Thank you, everyone. Thank my panelists also. Ms. Roshni, you want to give any session final conclusion?
Yes, sir.
We are concluding the session. Thank you so much.
Thank you, sir. Thank you, sir. Thank you so much
Thank
for
you, sir.
joining today.
Thank you everyone for the opportunity. I thank all my panelists. Thank you.
Thank you, sir.
Thank you, sir. Thank you so
We
much.
thank all the faculty and the participants has joined today. We'll hope to see you in furthermore events. Thank you. Good evening.